Hi, and welcome to this education session. My name is Andrea Polkinghorn. I'm a registered nurse, and I work as the lead immunization strategist for Stanford Health. I'm here today to talk to you about essentially why there is a new recommendation to start giving the HPV vaccine starting at age 9, and how we implemented that for our healthcare organization. So the objectives of this presentation are to discuss updates to the clinical recommendations for HPV vaccines, recognize the value of starting the series at 9 to 10, differentiate between what is on time versus catch-up vaccination, and describe the revisions to current systems for our healthcare organization to implement these updated clinical recommendations. So next, I want to start out this presentation by talking about what the actual immunization recommendations are from the Centers for Disease Control and Prevention. The CDC recommends that all 11 to 12-year-olds receive a complete HPV series. They do indicate that you can start the series at age 9. I want to point out that the CDC splits the immunization schedules for those from birth through the age of 18 and 19 and older, and therefore the routine recommendation to ensure everybody has a complete series goes through the age of 26. And lastly, just to mention that there is a shared clinical decision-making recommendation for adults 27 through 45. So first, we're going to discuss barriers to HPV immunization. The first that I like to point out is that there's this perception out there that this vaccine is still new, when in reality, it's been out for 17 years. There's also this concern that the vaccine isn't safe, when we actually have over 15 years of safety data that proves that it's not only very safe, but very effective. So another barrier is that there is a lack of the HPV vaccine being required for school in comparison to the Tdap and meningococcal vaccines. A lot of parents or guardians, when they come in, indicate that they only want to get their child what is required for school, so that creates a barrier. So as children age, there is a reduction in the return for an annual well-child exam. So if they're not coming in, we're not going to have the ability to update immunizations. Well-child exams are often the place where immunizations are most commonly addressed and updated. So again, this is a barrier. There's also this perception out there that vaccines are mostly just for infants and young children, when we actually need vaccines for our entire life. Another barrier that presents is sports physicals. So often this is what parents will use for their annual exam for their child. And many sports physical forms do not require the healthcare provider to assess immunizations. Therefore, unless they are intentional about making this as part of their sports physical, it's a barrier and a missed opportunity to update vaccines in general. There's also just a lack of awareness about HPV disease incidence and how it's transmitted. I don't believe a lot of people know or understand that an abnormal Pap test is often the result of HPV, or that HPV is most often commonly the cause of genital warts. There's also this sexual taboo relative to HPV. A lot of parents or adults are uncomfortable talking about sex with younger youth, and or don't want to think about their child potentially engaging in sexual behaviors. Another barrier is that immunizations or vaccine recommendations are just challenging to stay up to date with. They're constantly changing. We're getting new vaccines, or we have new data that supports the change of the recommendations. Now, somebody like a family medicine doctor is not only juggling staying up to date with immunizations, but things like diabetes and Pap tests and all that stuff. So it's really challenging for healthcare professionals to stay up to date on everything. Also, there's this perception out there that remains that the vaccine is mostly needed for females, when in reality, it's also needed for males. We have a lot of data now that talks about the incidence of oropharyngeal cancers in older men, often associated to HPV. So now we're going to jump into why is there this new recommendation or best practice to start at ages 9 to 10. I want to talk a little bit about national data that we have available to evaluate immunization rates for HPV. I want to point out that this data evaluates the vaccination or immunization rate for 13 to 17-year-olds, not 11 to 12-year-olds. Therefore, we should see higher rates in 13 to 17-year-olds because ideally they should be complete by age 13. There's also been this gender disparity between males and females. Now, part of this is associated to the fact that it wasn't recommended for males until 2011. Before I jump into that gender disparity a little bit more, I just want to update you on current immunization rates for HPV. So for 2020 to 2021, those 13 to 17 years who had one dose or more of the HPV vaccine increased from 75.1 to 76.9%. For those who were considered up to date, which is essentially they have a complete series, it increased from 58.6 to 61.7. So as you can see, for those who are complete, we definitely have some room for improvement there. Last thing I want to point out relative to national trends is that some of this NIS teen data for some years, we only saw an increase in the immunization rates for males and not females. So we're closing the gender gap, but not necessarily are we doing a better job vaccinating females. So again, this is from the National Immunization Teen Survey. I want to point out the data in orange there, which outlines the difference between the rates for females versus males for a complete HPV series, or what's referred to as up to date. Now you'll see on the far right, in 2016, the difference between these was 12%. Now, when we look at 2020, you'll see it's reduced to 5.4%, and most recently in 2021, it's 4%. So we are doing a better job getting more males vaccinated, but in general, we still need to work to improve rates. This slide here, what I want to talk about again is those vaccines that are due together at that 11 to 12-year-old time frame. So not only is HPV due, but so is Tdap and meninge. And we see this huge disparity between rates for HPV versus those two vaccines. So you'll see on the right there, in the yellow is the combined rate for males and females. And in the top, blue and green are the rates for Tdap and meningococcal. So ideally that yellow bottom bar would be all the way up to where that blue and green are on the way top. Just for your reference, I did provide the specific male and female breakdown. Now, I really like this poster from American Cancer Society, and I promote it pretty widely within our organization. And essentially, what it's lifting up is that on-time vaccination is between the ages of 9 to 12. We want these kiddos complete by age 13. Anything 13 or after is late and technically catch up. And I think we need to both educate the public, but also healthcare professionals to think of it in this way. This slide here, I wanted to point out just how much more valuable it is for the vaccine when we give it at a younger age. In the gray bar, this is before we had the vaccine available and the prevalence of HPV in females. And then on the far right, the data is from 2015 to 2018, but you'll see the huge decrease in prevalence when we give the vaccine at these younger ages. On this slide here, I want to point out the middle column that is titled percentage probably caused by HPV. On the far left-hand side are the different types of cancers. So what this is pointing out is 91% of cervical cancers are caused by HPV. 75% of vaginal cancers are caused by HPV. So what I wanted to point out here is if we can do a better job of ensuring everyone is vaccinated, we have a really good chance at severely reducing all of these cancers. On this slide here, I want to point out the picture on the right. This is from CDC's Teen Vax View, and it provides you the immunization rates for HPV for each state. As a reminder, these are rates for 13 to 17-year-olds. So theoretically, we should expect them to be very high, but you'll notice that there's a lot of lighter blue indicating lower rates. Nationally, they don't evaluate immunization rates for 11 to 12-year-olds. So you would have to do this internally, but at Sanford, we did that and we saw a reduction of around 30 to 38% for 11 to 12-year-olds in comparison to rates for 13 to 17-year-olds. So what this is saying is that we're not doing a good job of ensuring that these kiddos get a complete series by the age of 13. So for all of these reasons, the American Cancer Society and the American Academy of Pediatrics established a best practice for providers to start to give the vaccine at 9. So when we start at age 9, we really have a dual benefit of improved immunity and a higher chance of increasing completion rates. By starting earlier, we have more time to get these kiddos complete by age 13. Also, the younger that we are, the better our immune system works, so they have better uptake or protection from HPV. When we give the vaccine at a younger age, thankfully, there's a 2-dose vaccine series in comparison to a 3-dose series that's needed if it's given at age 15 or after. Also, when we give it younger, it better ensures that we're likely protecting these children before they're exposed to HPV. When we give it younger, providers have referred that sometimes it reduces the chance of the parents feeling that the vaccine will cause their child to become more sexually active because they're getting the vaccine. So it reduces some of that stigma because the child is just younger in general. It also eliminates that conversation about vaccines required for school. So if you think about it, ideally we could have the series complete before they present for that Tdap and meningitis 11 to 12, or we have the chance to get that last dose, that second dose, when they present for those vaccines as well. We know that there's no waning protection for at least 12 years. We have that data to support that. So that's not a concern that we give it earlier and immunity wanes. And so lastly, there's really no identified downside to us starting this series earlier. So now I just want to provide an evaluation of where immunization rates are relative to the COVID-19 pandemic. You'll see on the far left there, that huge dip below the trend line, which was right when the pandemic really hit in March and April. And you'll see on the far right, in August of 2022, we still remain below that benchmark or that threshold. So we haven't fully rebounded from the pandemic and when we got behind. So I want to talk about a little bit about immunization neighborhood. And essentially what this is saying is that all of us within the healthcare space have a responsibility to support immunization. So yes, we have vaccinating providers and retail pharmacies, but we also have people like you who can support immunization efforts based on people that you serve or your members. And so I would consider you guys a non-immunizing provider. You have members, you can promote immunization, but you don't do the physical vaccinating. It really just takes people constantly hearing the message to ensure that we are getting people up to date with their vaccines. In reference to things that a health plan could do to support immunization efforts is if you haven't pulled your immunization data for your members for HPV, that you look at that. Often when you don't have that data, there's this perception that we're doing a better job than we actually are. There's also an adolescent HEDIS bundle measure that health plans can use to evaluate immunization status for 13-year-olds. It evaluates 13-year-olds who have a dose of Tdap, a dose of meningococcal vaccine, and a complete HPV series. Now, I would tell you for any of those that fall out, it's very likely the HPV that has made them not meet the mark. You can also do a reminder recall for your members, letting them know that they're, now due for this vaccine, or maybe they're behind. Anything to help people remember that they need to get these vaccines. Educate your members. So we talked about a lack of awareness and understanding about what HPV is and how common it is. So the more that we can get information out there to educate people, the more informed they'll be and hopefully seek vaccination for their child. So I wanted to talk a little bit about the evidence behind those recommendations. We've weakened our recommendation for vaccines in the healthcare profession a lot since COVID, but just in general. We seem to recommend things like medication or treatment more as a statement or a fact, but we kind of lift up and almost ask it like a question for vaccines, when in reality, it's no different. And so you should use a strong presumptive recommendation, bundle the recommendation so that you're offering all vaccines or recommending all vaccines the same way on the same day. And then to tie into that, there has been evidence that when you put the HPV vaccine in between the Tdap and meningococcal, depending on the comms, that there is better acceptance of that. So I would just advise you that if you're going to print materials relative to the other vaccines that are due, the HPV isn't listed at the bottom. Potentially, you guys could help inform your members when they're overdue for a second dose of HPV vaccine. Securing that return visit is a downside. So there's evidence out there that yes, starting at 9 to 10 helps get them started, but we still need to continue to work to improve series completion rates by age 13. Maybe you could, if you're going to be a champion, reach out to a vaccinating provider to coordinate a vaccine clinic, or at a minimum, help promote one where people can go and get vaccinated. So now I'm going to jump into what we did at Sanford Health to implement this best practice. For a little bit of information about our organization, we're mostly based in the Midwest, North and South Dakota, and the western part of Minnesota. To give you an idea for size, we have 46 medical centers and over 200 clinics. So this was really the strategy, or really any strategy that I used to implement something like this. So first, you got to kind of build your case, right? So pulling immunization rates, really explaining about why this practice change is needed. Then I take this information and present it to C-suite leadership and also groups like family medicine and pediatric department chairs. If you can get them all on board, then you essentially have the support to move this work forward. So after I get that type of approval, I really work with groups like IT to make modifications to the electronic health record system to support this change. We are on Epic at Sanford Health, and so we had IT modify the provider prompt and dropped it down to age 9. These provider prompts are really what our staff are familiar with to remind them to address immunizations. And so had we not made this change, likely they would not have remembered to start giving the vaccine at an earlier age. Also, sometimes there are restrictions on certain medication orders. So we had to ensure that the order for HPV was allowable to be ordered as early as age 9. And then lastly, we do have nursing protocol orders, or you may know them as standing orders. And so we had to get that updated and revised so that nurses could initiate the HPV series at 9 instead of waiting till 11 to 12. So after we have those things in place, it's really time to educate all of our staff. So we typically host multiple live webinars where we explain the best practice, what it is, why it exists. Because we have their attention, we usually provide updates on updated clinical information or maybe data that has been available since the last time that we talked about it. We also often discuss participatory versus presumptive recommendation, which I kind of talked about key strategies for health systems relative to your communication. We talk about interventions that they can use to help improve immunization rates, or better yet, have office visits where it's successful that at the end of that visit that the patient is leaving vaccinated. And then we inform them of the go live date. So we got to give them a little bit of time after we educate them to prepare things within their clinics to be ready to go live with this. So because there is a time frame in between staff education and go live, we do use our internal communication methods to help remind end users of that go live date. So outside of that initial strategy, there are a couple of supporting strategies that I often use to support this work. One is we have a very robust HPV report that we run. So we had to modify that to incorporate immunization rates for 9 to 12, in addition to those 11 to 26. We have an internal program for nursing staff where we educate them about all things vaccine. As part of that program, they have to implement a performance improvement project, and HPV is often one of the vaccines focused on because the rates are lower in comparison to other vaccines. Our quality cabinet tasked our pediatric department with determining some pediatric measures to put on our performance improvement plan. One of the measures that they decided on was the adolescent HEDIS bundle. So this will give us some additional support on improvement work. Obviously, when we implement any new program, we have to evaluate if it's successful. So we really use that internal immunization report to evaluate, are we seeing an increase of the number of 9 to 10-year-olds who at least have one dose? We also, because of that HEDIS measure that was established as a key priority, we're going to add it to our immunization dashboard, which is really where clinic leaders or people in quality look to provide a more summarized version of how we're doing. And then lastly, there's been lots of funding out there for working on HPV improvement. And so we have had and continue to have several grants to focus on improvements in this work. So that is all I have for you today. I have provided my references there for you should you want to look anything additional up. Thank you.